This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Hi, I'm Jim Denaney, the Executive Vice President and CEO of the American Academy of Otolaryngology, Head and Neck Surgery. I'd like to welcome you to episode 12 of our COVID-19 podcast series. This episode accompanies the release of the Academy's new document, Guidance for Return to Practice. Today, I have a great panel I'd like to welcome of members who helped us prepare this document. I'm joined today by Gavin Setson, past president of the Academy and chair of the Future of Otolaryngology Task Force, and a partner at Albany ENT and Allergy Services. Also, past president Ron Cooper-Smith, a partner at Texas ENT and Allergy and professor of surgery at Texas A&M Health Science Center for Medicine. Stacy Ishman, the surgical director for the Upper Airway Center at Cincinnati Children's Hospital Medical Center, and Mark Dubin, chairman of the board of managers for the Centers for Advanced ENT Care in Baltimore, Maryland. This afternoon, we are releasing our guidance document for return to practice. This was produced with input from the surgical specialty societies within otolaryngology as well as the Academy committees and reviewed by their boards of directors, our board of directors, and finally put together by the Future of Otolaryngology Task Force. All of the panelists today represent that committee. So Dr. Setson, Dr. Cooper-Smith, Ishman, and Dubin, thank you very much for all the work you've done in a short period of time to produce this document that I believe is going to be quite helpful to our members. I'd like to start with a question for you, Dr. Setson. Can you describe the multiple contributions made by the specialty societies and academy committees that helped shape this document?
Certainly. Thank you, Dr. Denaney. And I think it became readily apparent that there was a clamor and need amongst otolaryngologists across the breadth of our specialty for guidance of this nature. And because of the complexity and diversity of our field, input from all of these specialty organizations under the auspices of the Academy became necessary. I think suffice it to say that this is not a standard of care document. It's not a clinical indications document, but it is really meant to give guidance and looks at the crisis that we are facing and an opportunity to return to care. So given the complexities involved, this required collaboration between the Future of Otolaryngology Task Force of the Academy and its foundation, working together with the board of directors, the Patient Safety Quality Improvement Committee, the Infectious Disease Committee, and the breadth of our specialty organizations, including, and I'll list them, the AAFPRS, the AAOA, ABEA, the ALA, ANS, AOS, ARS, AHNS, and ASPO. And it was an enormously collaborative process working with the corresponding committees in the Academy and Academy staff as well to produce robust guidance. And because of the complexity and the timeliness, we decided that it would be important to release this in two phases. The first phase, the guidance document that is being released today, is applicable to the entire specialty. And for that reason, based on its importance and timeliness, this will be released today, and I think will be enormously helpful. The other submitted recommendations will be subspecialty specific to the organizations I mentioned, and that document will be forthcoming. So this was really a we are one moment, a highly collaborative process with incredibly important input from every specialty in our organization, and I think will provide important guidance moving forward. So thank you to all of those involved. There were many people at many levels who contributed to this process.
Thank you, Dr. Setson. Because of the list that we discussed, we did omit one who's actually on the call, and that's the Surgical Sleep Society, International Surgical Sleep Society, who's also contributing to that. I didn't want to let that slip by. Dr. Coopersmith, how do you think this document will be used and can be used to help people get back into practice in the office, surgery centers, and hospitals? And what do you think will be the effect of putting this out for the members?
Thanks, Dr. Delaney, and thank you to the task force. It was really a pleasure to be part of this. I think this document is really an important piece of guidance because it provides a framework to think about how to return safely to practice and address issues related to potential exposure, what the appropriate PPE is in different situations, issues related to current testing, issues in how to manage your office and how the office flows, considerations within the operating room. And I think that this can be used to help set policies and procedures within your clinic. It could be helpful to educate staff, and I think it'll be very helpful for physicians to be able to educate either administrators or employers that may not be completely familiar with issues related to our specialty. And so, you know, and it's a living document, I think, that's been mentioned. And so with time, as more evidence comes, hopefully we'll be able to refine the recommendations. But I think this is something that's going to allow us to return safely to practice, to be able to serve our patients, protect our staff, protect ourselves and our families.
Thank you, Dr. Coopersmith. Dr. Dubin, could you discuss the different types of evidence and the process going through putting this document together? As most of our members have seen, there's many postings on the internet. Different states have different rules, different organizations have come out with different recommendations. Could you kind of go over the way this was put together, using all that information to try to give the best guidance for our members, given the fact safety comes first and then the need to continue to give quality care when we do see the patients?
The challenge of the current crisis across the board with COVID-19 at all levels is that the data on everything is almost uniformly anecdotal. We do have some data, though, on what is the high concentration of viral particles in respiratory mucosa, and that generating a cough or a sneeze can widely spread respiratory droplets. We also know data on what is protective on PPE and the sensitivity, specificity of the varied testing that's on the market, which changes on a daily basis. The challenge is that we then move on to a whole bunch of anecdotal stories and theories that have not necessarily been proven. Not saying they may not be true, but or eventually proven, we just don't know. The concept is that our procedures can create aerosols when we manipulate the mucosa with a variety of instrumentation. What has then occurred is that we've taken this anecdotal concept and or theory and extended it to explain that the reason that ENTs, amongst other specialties, have been shown to be more infected in countries that are ahead of us on the curve is because of these procedures. It's very clear there is no data on the direct spread in this manner from any ENT procedures from a patient to another person. We do know that there is an anecdotal report out of China of a pituitary case that has since been refuted by the primary team that attributed that spread to postoperative care that was provided by providers who were not wearing appropriate PPE. With all of that, the document uses what information we have with best recommendations and expert opinion by the leaders in the field. And that's truly the best that we can do right now. This document has been widely circulated amongst all the subspecialty societies in the leadership of the academy. And what has resulted is that the comments and suggestions and recommendations that are in this document that are currently based on the evidence, limited data, and expert opinion that we have right now are appropriately cautious, but don't disproportionately restrict patient access to care without any substantiation.
Thank you, Dr. Dubin. I'm going to give you a real hardball here, Dr. Ishman. Why don't you discuss your thoughts on the current status of COVID testing? as you're aware, every day in the lay press, it comes up trying to decide who has this, who spread it. If you've had it, can you get it back? And there's some weaknesses in the testing program that we have available. Would you please discuss that for us?
Sure. There's a couple pieces. One is there's two main types of tests. There's those PCR tests, which are looking at usually viral RNA. Those tests have varying levels of sensitivity and varying times to how quickly you can get them accomplished. So some of those are being used for point of contact testing, and the specificity is usually pretty good on those tests, but the sensitivity is really the issue. And that's affected by a number of factors, which include the method in which you have taken the sample and the timing in which you take the sample. So if people are symptomatic and they have a positive test, we believe it. If people are asymptomatic and they have a positive PCR test, we believe it. The problem is when patients are testing negative with or without symptoms. There's very little data regarding, especially so many of these are sort of homegrown PCR tests. And so the FDA has done a great job of trying to approve them so that we have some level of testing, but the sensitivity rates are all over the board. So there's testing that came out of China that they talked about being as low as 60% sensitive. There are places where testing is probably somewhere more like 80%. There's currently a commercially available test from Abbott that's fairly quick, but it can only run one patient at a time. And so you can't take care of all your staff when they walk in the door in terms of testing them if you have concerns. And so that's why, to this point, most places have limited testing to either patients who are symptomatic or staff who are symptomatic. But I think more and more, as you'll see in this document, we were really recommending that if you're going to think about non-urgent surgery, that testing is going to be critical to understanding both the safety of doing that surgery to the patient and all of the people in the room, and also whether or not you have to use a higher or lower level of PPE. And so the PPE burn rate is really going to be dependent on how effective we are in terms of testing. The other piece, and even I looked at the CDC website this morning, as of today, they still really don't understand the value of the antibody testing. And so that's the IgG and the IgM testing. And so a positive IgM test, you can probably rely on the fact that you should treat that patient as positive. But the IgG testing is concerning. It takes 11 to 24 days for you to understand if people are going to be positive afterwards. We think it lasts for months. There are cases that have come out of South Korea of people who had positive IgG and then were reinfected, or it came back. It's unclear. And so it's not entirely clear that that people who've had the infection and that the test shows a positive IgG test is either sensitive enough or that you might in fact be able to reacquire this infection. And so I think there's no guidance currently, either from us or from some organizations like the CDC, on what the utility is of antibody testing.
Thank you very much, Stacy. One of the things that I'm sure the members are wondering about, as quickly as things are changing on a weekly or even daily basis with what we're hearing, could you explain, Dr. Setson, how this document will be handled? Is this a one-off, or are we going to revise it as needed, make it a living document?
Certainly. And I think that really is a critical differentiation here, because as was alluded to, much of the data and information currently is anecdotal. And as more science and rigorous data does become available, the recommendations will be updated on a continuous basis to reflect the science that's currently driving the direction of how we go about diagnosing, treating, and protecting ourselves and our patients. And I think that's going to be the key to this document, that it will be a living document, updated as need be. And I think it speaks to a lot of the comments that Dr. Ishman and Dubin made. There's a lot of uncertainty. There's no discrete guidance. We're dealing with theoretical concerns regarding transmission risk, and it's very much patient dependent, procedure dependent, and will modify accordingly as we go forward.
Thank you very much. One of the things I think most of the listeners will be interested in is what are you doing to prepare your office and staff for your return to practice? And three of you are in private practice, Dr. Dubin, Setson, and Coopersmith, and Dr. Ishman's in an academic practice. So I'd like all of you to give a brief comment on what you are doing, and I think we'll see some differentiation, but all leaning toward the safety side. Why don't you start first, Dr. Ishman?
So we've actually separated out the procedures that might be done in our clinic from the clinic visit itself. So we have a regular clinic, but we aren't scoping people. We aren't doing frenulectomies. I have a primarily pediatric practice. And some of the other things like nasal scopes, we're bringing people back for a procedure clinic in which a higher level of PPE is going to be used throughout the day. So you'd start the day with an N95 mask, and assuming it doesn't get soiled, use it throughout the day in order to take care of kids in a procedure clinic, with the idea that we would have a little bit of time for clearance in those rooms if there's going to be coughing, sneezing, and some other things that may come up, or quite honestly, objections from our patient population who are not always excited to get a scope. And then in terms of scaling up, we actually are doing some social distancing in the waiting room. We're doing our pre-op, pre-clinic conversations with the nurse are being done by phone so that we can minimize their time in the room. And we're able to bring them right in and not have really anybody else, trainees or otherwise, in the room so that we can minimize exposure.
Dr. Coopersmith, would you like to tell us what's happening in your area at your office?
Yeah, thank you. One of the things I wanted to point out is the guideline or guidance, it's not a guideline, the guidance recognizes that there are going to be local differences, especially in areas of testing and availability of PPE, may be very different in a big hospital setting versus, a smaller town clinic or even a smaller private practice in an urban area. We're trying to follow most of what's in this guidance. We're very concerned, obviously, about the safety of our staff and that they feel comfortable, because if the staff isn't comfortable, I think we want everyone to feel comfortable that what we're doing is safe, because I think that helps the patients feel more safe. But we're doing things like social distancing, using dedicated rooms, for doing endoscopy, and pretty much only using those rooms for that, because we have the space. We've slowed down the number of patients that we're seeing so we can accomplish this distancing. We've had the fortune of unexpectedly, this coming along like everyone else while we were going through an electronic medical record transition, which has only made this whole experience that much more fun. But it's given us an opportunity, since we're not going as fast, to spend some more time, working out some of the issues related to that. And then just trying to, make sure that we stay ahead of our PPE needs. I think Dr. Ishman mentioned, PPE burn. And I think that can become a big issue in a busy clinic where you have a lot of patients coming in, a lot of different providers, different staff, and making sure that everybody's, we have everything we need to keep the office clean and to keep everyone protected. And I think, not in the old scheme, you would call your supply person and 3 days later, everything would show up. And now you call them and, it's kind of like ordering groceries online. Sometimes you get what you ordered and sometimes you don't. And so we're trying to just get ahead and really keep track of the inventory and make sure that we don't run out of simple things like the probe tips that you need for taking people's temperatures. If you run out of anything, whether it's a cleaning agent, it's masks, it's face shields, it's temperature tips, hand sanitizer, it really puts you in a tough spot. And if you're a small practice and you don't necessarily have the leverage of a big institution, it can be a bit of a challenge. And so we're constantly paying attention to that.
Dr. Dubin, what's going on in Maryland?
We have been essentially seeing, as everybody, only urgent and emergent patients over the last 6 weeks. And as everything screeched to a halt pretty much in what's a hot zone, pretty much hotter than almost everywhere except for New York, we've been very limited in our patient volume. So the fortunate thing in that is over the last 6 weeks, we've been able to figure out pretty well the appropriate protocols we need to slowly ramp up. I echo what Ron said, but we've found that screening to be also very critical as well. We do that both we ask the questions honestly that are in the document, both at patients making their visit and showing up at the door, and nobody gets in the office with any symptoms that are concerning for COVID-19 infection without speaking either to a physician or to a physician via telemed visit, and not minimizing the risk of seeing an asymptomatic COVID positive patient in the office. It's reassuring to everybody that we have that protocol in place. I think that's critical moving forward for us. We spent a lot of time adjusting our office space, changing flow, checkout procedures, et cetera. And I think the key to, we are confident in the safety of our office at our current volumes, and we're ready to gradually scale up. It's critical that we don't just jump back into a full patient volume, because I don't think that's actually possible with the increase in precautions and time and room turnover, et cetera, and having appropriate expectations from my partners that that's not the case. And most importantly, I think it's communicating the safety to the patients and knowing that them knowing that their safety is our primary concern, and all the things that we're doing so that primarily they are safe and that we are safe and we can provide the care that they've been missing over the last couple months.
Dr. Sutson, do you have anything to add to that?
I think most of the reopening procedures are similar. What I would encourage is as much use of digital technology and other measures, including for insurance pre-certification and the like, where patients are returning who may not have been in the office or have lost employment, and there are issues in that regard. A lot of that face-to-face time can be replaced by online workflow and digital workflow prior to the visit. We are also checking temperatures of every patient who comes in the office, potentially oxygen saturations as well. Every patient down to age 2 has nasal and mouth coverings. Every staff member constantly has a face mask. And so I think, to Dr. Dubin's point, patient confidence needs to be re-earned, and they need to see that we are doing the things that we talk about. The utility of the document is that it walks through each stage of the potential patient encounter, giving guidance for the pre-visit, what one can do with staff, what one can do in the clinic and exam room afterward, et cetera, to limit potential exposure, contact, and risk. And I think it's important all the way around. Checkout procedures are much different. We have patients leave directly from the examination room, and we do what's called an online checkout, and any materials are sent to the patient through a portal, appointments are made, and testing facilitated to limit any potential spacing issues and contact. So I think these are all important issues, and they are reflected in the document.
Hey, thank you. Dr. Cooper-Smith made a point that I think is critical, and that was the safety of the staff. But one of the things that I think may vary across the country is most of the staff are similar to patients, and they know they're going to be more exposed. Are you doing anything special to educate them before they're coming back, or how are you handling that? I mean, I know there's great concerns, particularly in the hospital areas, surgery centers. Any thoughts on additional educational or other opportunities with staff as they're ramping back up to seeing a normal type of patient as opposed to just urgent and emergent?
Well, I think that's an important consideration, because just as patients have fears and insecurities, staff do as well, if not more so, because of their potential exposure. So having a well-documented return safety plan reviewed with staff, signed off by staff, is important. We have access to CDC and other videos for staff regarding Oneoff and on with respect to PPE and sanitization procedures and the like, and ensuring that protocols are adhered to. That's the key thing, so that staff have confidence that they have availability of PPE, they are well educated, and that's a team-based approach to solving the problem. And I think that was very helpful in our setting, and something that's emphasized in the document too.
Stacy, in an
What else?
academic setting, is there anything different than you've heard? I know most of the private offices directly employ their staff, and when in my teaching institutions I've been at, we really had limited control of the staff as to who was hired and how the policies were. Have you had any thing at Cincinnati that's being put forth to the staff, or have you heard of any of your colleagues and academics how they're handling it?
I mean, even though we don't directly hire all of the staff, I think the same kinds of concerns are fairly universal. I mean, I'm in a hospital-based clinic, so we are located in an attached to the hospital. And so we are able to take advantage of some of the things that come with that, including the fact that everybody walks in the hospitals being screened very similarly to how everybody else is mentioning it. And we've managed to do things like infrared for thermometers, so we don't have to worry as much about contact. And there are some pieces like that, if people can use them, that can be useful. Also talking to the staff about things as simple as wear scrubs, that you're not going to have contact with your family with necessarily, wear clothing that it's not your regular everyday clothing. You walk in and change and put your scrubs on and then leave them at work and go home with some other things. And so I think we do get some of the advantages because of the scale of the response. But it has the same problem with the fact that there's probably far more people walking in the front door of our institution than there might be walking into an office. And so social distancing and things like registration become an issue. So coming up with alternative ways to do those. I love the idea of an electronic checkout like Gavin's talked about. And so trying to do as much of that by telemedicine too. I think we have had the same thought that if we actually right now are trying to be at 50% of our volume, and a third of it is supposed to be in person and 2/3 by telemedicine. So the real key, honestly, is going to be working with the insurers to make sure they understand that new patients can be well taken care of, at least for initial visits and test follow-ups and things like that. And so the advocacy in that regard from the Academy and other organizations is going to help all of our patients to stay safe in that way.
One of the most common, if not the most common question in back to practice revolves around diagnostic endoscopy, whether it's nasal or nasopharyngeal, laryngeal endoscopy. And we've had input from the specialty societies, but I think this warrants a specific discussion among the group about the endoscopy in all ages. I know Dr. Ishman is in the pediatric group for the most part, but the rest of you all see different ages. Who would like to start? Dr. Dubin, why don't you start with your thoughts on the endoscopic issue?
Sure. First, we spent a lot of time on these considerations, and as people read through the document, I hope they'll appreciate that. There's a wide range of thoughts on this topic, on the potential for endoscopy to be a quote unquote aerosol generating event, and we discussed at length all the different information that was available at the date that we wrote it, and we'll continue to modify it accordingly. And the recommendations that are in there are based on the fact that, with some degree of logic and the data that's available from the paper that's published from Harvard, the cough and sneeze associated with that procedure is the predominant risk in the office setting. And the predominant risk of the cough and the sneeze is in the outpatient setting, almost uniformly, is the asymptomatic patient that makes it into the office who's COVID positive. And the recommendations that seem to be appropriate at this point are wearing an N95 because of that risk or sneeze and cough. And acknowledging that there is an increase in costs associated with that increase in PPE until the data becomes more clear. that does appear to be something, in the opinion of the task force and my personal opinion as well, that is an appropriate precaution for the staff because of that risk of sneeze and cough.
Ron, do you have any thoughts on that? And one of the things I'd like to weave into this discussion is someone that's sitting in the Baltimore area and in a larger group may have considerably more access to the PPE that you were talking about burning, but someone in Little Rock, Arkansas, or smaller towns may not. And we did consider those factors into these recommendations. You might want to talk about some of the flexibility of this, and if you want to comment on the table that's in the document, I think that'd be helpful to the listeners.
You know, I think this is obviously a really important discussion, and one of the great things about this task force, and we had input from all the subspecialty societies as well as the board, is that you had everything like a private practitioner in a small town that's not being affected a lot, to people who are in hospitals that are predominantly COVID positive, and scoping people. And so we had a really good discussion about this. And I think the way that we stratified it, one of the key tables that's in the document kind of looks at three different things. It looks at COVID testing status, instrumentation, and then if there's an intervention that disrupts the respiratory mucosa. And looking at those different factors, helps inform what type of suggested minimal PPE people should use. And I think that where some of the flexibility comes in has a lot to do with testing. And so and I think in terms of testing, as Dr. Ishman talked about, I think there are local considerations. If you're at the Mecca and they're doing, highly sensitive and specific testing with low false negatives, and you can be very, very confident that a negative is a negative, there may be an opportunity eventually or potentially even now to de-escalate PPE. But if you're in if you're in a location where, maybe there aren't as many cases and there's not as much confidence in the testing, that we're really advocating for people to be safe by using an N95 and eye protection. And so I think by looking at things in this way, confidence in testing, it's kind of like, FNAs, the testing. If it's positive, it's really helpful. If it's negative, it's a little bit less helpful. It's a little bit less uncertain what that means. And then obviously a lot of the patients that we're seeing in clinic are going to be an unknown status because they haven't been tested. And so, you have to assume that potentially these are asymptomatic carriers. And then it's looking at what you're doing. Are you doing something with, with a drill? Are you doing something that's going to create a thermal plume? Are you doing, something that there's going to be, that's going to cause sneezing or coughing or a lot of droplet formation? If you're just removing a skin lesion on the neck, you probably aren't doing those sort of things. It's a less, and the instruments that you're using, it may be a lot less risky as opposed to disrupting respiratory mucosa and using instruments that may either cause coughing or instruments that may cause some sort of aerosolization. And so I think we have a nice way to look at this for now. And this is something that I think we'll be keeping a very close eye on as more data comes out and modifying and hopefully de-escalating in some areas to make it where it's more feasible.
Stacy, how is your institution handling those type of procedures?
So we are having lots of debates about whether or not there's enough N95 masks in order for everybody to be able to use them for all of these negative or unknown patients, even in the procedure clinic. The institution is not entirely convinced that our procedures require that, and that is not the institutional norm for other folks' procedures. And so, quite honestly, this guidance will be useful for us in terms of continuing that conversation. The other piece that I don't know that we've mentioned is about using atomizers or nebulizers. And one of the things we've included here is that while it's not really addressed in much national CDC kind of guidance, there is a real risk of aerosolization with those kinds of things. And so we are recommending they not be used for things like scopes. And we have instituted that at our institution.
Thank you. As we close this out, I would give each panelist an opportunity to mention something that they think is important that we may not have touched on, or specifically reemphasize something. And let me start with you, Mark, and I'll give you the last word, Gavin, since you were the chair of the task force.
Yeah, I mean, I don't know. We touched on a lot of things, and the document does a really nice job as a starting point. And I know it was mentioned, but I just want to emphasize that, for those people listening, check back at this on a regular basis, because as the data becomes more clear, the recommendations are going to change. As a negative becomes a real negative on testing, and testing becomes availability, this is all going to change, and I look forward to that. And we've tried to do a nice job of being safe yet not overly restrictive. And the committee's recommendations, the task force rather, recommendations were uniform and agreed to across the breadth of academic chairs to private practitioners, from rhinologists to pediatric otolaryngologists and sleep specialists. So thanks.
Stacy, any last thoughts?
Just that we've talked a lot about things like N95 and testing, but you can't emphasize enough the basic screening, wearing masks, and social distancing. And I think in an office setting, doing things like social distancing are hard. So Mark's comment about rejiggering the office or the waiting room to make sure that it's appropriate are going to be really fundamental.
Ron.
Yeah, I would echo the things that Dr. Ishman and Dr. Dubin said. I think the document's excellent. There's a lot of very practical advice. I think that, we recognize that this is a moving target, that we're in the fog of war, that, there is an absence of evidence. And I think that this provides a safe way for us to move forward. There are a lot of interesting ideas and theories and things like that out there, and maybe some of those things will pan out, and we're monitoring them. But we think this is really a common sense approach to helping people get back to helping their patients, to managing and keeping their staff safe. And it's really was a really great process to be part of. Learned a lot, and I think that this is a valuable contribution to the specialty.
Well, Gavin, as we finish this out, would you mind going over what the listeners can expect next week when we release the surgical prioritization part and how they'll fit together?
Certainly. So, given the enormity of the situation and the relevance and impact moving forward, once you read the document, you will see that the goal was to provide a common denominator that would allow every otolaryngologist to safely provide care in any setting, in any part of the country, recognizing that whatever the recommendation, there may be changes that will occur on an ongoing basis, but additionally, guidance from local institutions, local healthcare regulatory bodies, CDC, et cetera, may supplant this. And so look to the document changing over time as evidence becomes available. Because this is a specialty-wide agreed upon approach, there are going to be differences within each of the surgical subspecialties within our field. And the second document, which will be forthcoming, will address those more specifically as it relates to stratification with respect to risk, urgency of procedures, timing of procedures, and so on. Again, it's not indications for surgery, but more timing as it relates to the crisis, resource availability, regulatory guidance, and so on. That'll be more specialty specific. And I think when you weave the two documents together, it's going to be the most consistent information and advice moving forward that we have to date. And again, this will change as needed on an ongoing basis. So We certainly have had a high level of collaboration, appreciate the input of everybody involved, and hope that this will serve your needs in providing safe, excellent otolaryngology care to our patients.
Thank you very much. I want to really inform the listeners to how much work that you all put in this committee in a very short period of time and turned around a fabulous document. So thank you for working on the document and this podcast. I believe this will be a podcast that people really look to, particularly when you combine it with the document, to give them guidance on how to start. And as you all mentioned, I think it is something that to check regularly, and we will, just as we have been doing with our notifications on a daily basis, if changes are made, we will notify you so you don't have to read the whole document every time you look into it. We will highlight when changes are made. So I'd like to also remind you not only to follow our COVID area on the website, but join the ENT Connect conversation to share information, discussions, personal stories, and inspiration with your colleagues. Now, and as always, it's very important that we are one, and we will continue to work on your behalf. Thank you very much.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.